Hey, welcome back. This will be your video lecture for Chapter 27, Immunologic Disorders. So in this chapter, we will talk about anaphylaxis. I know that's one of our topics here. Let me officially introduce the chapter to you. Let's see. So we're going to talk about specific and non-specific defenses against disease. We're going to talk about how the body protects itself from a multitude of pathogens that are encountered every day. We're going to talk about how when the body can't fight disease and if the system that it has fails, the illnesses that normally wouldn't pose a risk now can be life-threatening. Let's do an anatomy and physiology review. Non-specific defenses, right? So they can recognize a substance as harmful, but can't recognize exactly what that substance is, right? And so we have the skin and mucous membrane. So when we talk about the skin, it's pretty cool because it's a big defense. I mean, not only does the skin protect you from temperature-related issues, but it also, the pH of the skin is designed to where it's a little bit acidic. And so when a bacteria lands on your skin, hopefully it doesn't find its way inside you, and the acidity of your skin will actually kill it. We're going to talk about how antimicrobial substances such as blood, and we're going to talk about how interstitial fluid plays a role here. We're going to talk about natural killer cells. That's a type of white blood cell. We'll talk about phagocytosis. We're going to talk about the inflammation, how that's done, and where fever comes from. We'll talk about the specific defense or resistance immunity. We'll talk about B lymphocytes, T lymphocytes, antigens, and antibodies. So it's important to know that when an antigen is recognized, histamine, heparin, and other chemical mediators of inflammation are released. Now, the inflammatory response to histamine and heparin usually are localized, and it's actually beneficial. In anaphylaxis response, that system becomes exaggerated. So let me try to explain this a little bit so that we can kind of give you a base knowledge here. And the best way for me to do is to try to draw it out. So let's say you have an antigen right here. Let me kind of draw him over here. So this antigen, remember, the body doesn't really know what it is. It just knows it doesn't belong there. So it could be a bee sting. It could be venom. It could be bacteria. It could be a lot of different things. But somehow, some way, this antigen, the moon lined up perfect, and you've gotten exposed and now contracted some type of antigen. And so what these antigens like to do is they like to produce something called endotoxins. One second here. And these endotoxins will come in contact, and these are skin cells. This is your actual skin right here, and your skin cells. And what these endotoxins will do is they'll come in contact, right, with skin cells, and it produce endotoxins. And your book mentioned one was histamine. Oh, hang on one second. Before we get there, let's do this. Let's talk about this. A little different. So this is your your bacteria or your pathogen, wherever you want to call it, it's reacting with cell receptor sites of skin cells, producing endotoxins. And these endotoxins are going to meet the mast cell. They're gonna screw around and find out. That's what they're gonna do. Because it wants a war, it's about to get one. All right, and so it's going to, these endotoxins are going to meet up with the mast cell. So as these endotoxins come into the skin cells are also going to put off endotoxins as well. Why? Because it's damaging, trying to kill the skin cells one by one. So it's also going to release its own chemical mediators. But they're all going to attract this mast cell. This mast cell has been floating around, and it's actually waiting for this day so that it can be useful. And it meets up, and through the chemical process now, it's going to make something called histamine. So let's get a different color here. How about this? All right, histamine. All right, so it's going to produce histamine. All right. It's going to produce something called leukotrienes. I don't think your book mentions leukotrienes, but I could be wrong. If it does, great. We're talking about it. If not, we're going to talk about it. Heparin. All right. So those are the three that we'll talk about right now. And so as these chemical mediators here are produced by the mast cell, what are they going to do? Well, they're going to float up here, and they're going to meet up with the blood vessels. These are blood vessels up here. These are blood vessel cells up here. And they're going to start, and they're going to meet up here. So all of these are going to start affecting the blood vessels. And remember, this is a normal response. This is not exaggerated. This is what's happening if you get sick, or if this is what happens if you get a normal pathogen. And a lot of times, let's say, for instance, you cut your arm, all right, and it gets infected, right? It gets infected. The inflammatory response has been activated. And so what we see in the inflammatory response is swelling. We see pain. We see redness. And heat. Right? You know, when you cut your hand and it gets infected, it swells, it's painful. There's redness and heat. So let's explain this normal inflammatory response here. So what ends up happening is it's going to cause, through this histamine and leukotrienes and heparin, it's going to cause these cells to shrink. They're going to go in. They're going to shrink. Right? They become smaller. And I said shrink. The best word probably is to say contract. It's going to cause these cells to contract. And when it does, it leaves spaces in between. And I don't think I can erase. It won't let me, it lets me erase that, but it won't let me erase what I drew earlier. And that's okay. That's all right. But what it does, and let's talk about this, since this is the blood vessel, what's inside the blood vessel? Well, we have platelets. White blood cells, red blood cells. And remember, like I talked about, and we have plasma. And remember what I talked about before. Plasma can be leaked out. If you have a bunch of afterload going on, and that plasma it's coming through these blood vessels at the capillaries really quick, it can be forced out, right? Well, there's not a lot of afterload here. What happens is we have increased vascular permeability, right? Increased vascular permeability. Whoops. Causing that to shrink, making it possible that now there's a way out. And plasma now can leak out. And when plasma leaks into the interstitial space, what do we call that? One second. What do we call that? What do we call it when plasma? We call that edema. Or swelling, right? And as that edema comes out, it's in the form of plasma. It leaks out. It gets to that cut that's on your arm. What does it cause it to do? Well, it causes it to be swelling, which is edema. Also causes it to be red. Redness, right? And plasma is normally very warm, so that's where you're getting your heat from. Then you have pain receptors down here. They're like little neurons, right? Little neurons that are found there. And when edema presses on these, you're going to get pain. All right, so that's so far as a normal response. We haven't done anything crazy. Let me erase some of this so I get some space so I can draw some more. All right, so I just showed you how plasma comes out. So which one of these guys up here fights infection? Which one of these guys up here fights infection? Well, white blood cells, right? And white blood cells are in your blood vessels, right? We call it cellular blood, right? And normally, can white blood cells, platelets, get thrown out of the vascular system? Can they come out? No, not normally. Something has to make these white blood cells, because the infection's in the interstitial space. White blood cells just don't float around and stay inside the blood vessels like your arteries or veins. They have to come outside to fight this infection. So the same way that the plasma was able to leak out, so can these white blood cells, but it's through a little process. Sorry. I hope that didn't mess anything up. Now we're good. Through a process, right? You see these right here? These are called, I think they're called P selectors. P selectors. And so let's say we have a white blood cell up here. It's funny, isn't it? Because they have these little selectors too. And so when these white blood cells come through and they're rolling, right? They're rolling inside the vessel. That's how they do. They're coming through like that. They're rolling around. And as they come through, one of these P selectors is going to grab them. Because why? Because they match up perfectly. It matches up perfectly. This white blood cell is going to come down and it's going to get caught. And it's like, oh, somebody caught me. Where am I going? I was just floating through the vessel, but now something's attached to me. And what it does is it grabs it in the same way that the plasma was able to leak out through the vessel being contracted, now it gets pushed out into the intravascular space right here. I'm sorry, interstitial space right here. So now we have a white blood cell out here in the interstitial space. That process of where it rolls around is called diapedesis. I'm going to spell it right here. Diapedesis. E-S-I-S. Now, remember, I mentioned it, I think it was last chapter, about how white blood cells are like chemically respond. That's how do you think this guy's going to, how's this white blood cell going to find this pathogen, right? Well, all these endotoxins that are being put out are going to attract this white blood cell. And once it figures that out, it starts going towards that pathogen that's putting out those endotoxins. And that has a definition, and that's called chemotaxis. Chemotaxis. All right. So I think hopefully you're still with me. Hang on, I want to look at one other thing real quick. Antigens and antibodies. So now you see this white blood cell. I'm going to create another. Hold on one second. Let's erase some of this so I can get some room. Need a little room here to show you this. All right, so, whoops. So we have our white blood cell through chemotaxis finds this guy. It finds this pathogen. Get the right color here. Finds your pathogen, right? That's your pathogen. Let's get our white blood cell drawn out here so you can see it. And that white blood cell is going to go over here, and it's eventually going to engulf. It's going to suck that thing right in, right? Then, through something called lysosomes, it's going to break this guy down. To where it's like right over here. It's just going to break him down. He'll be over here. Right? And then he's going to actually do one or two things. He can put it at the top of its cell to be picked up by another white blood cell, depending on the type of white blood cell you're dealing with, or he can actually send it out into the circulatory system. It can be caught up by your lymph nodes, and another blood cell can come by, another white blood cell can come by, pick it up, and to make an antigen out of that. I'm sorry, make a like a, what was it called? An antibody. Can make an antibody out of that. So it's pretty cool. So that's how that works. All right. So if you have any questions, let me know. It's like 6 weeks of AMP2 put into you in about 10 minutes. But that's the basic concept. That's a basic response, guys, right? So what ends up happening in an anaphylactic reaction is you get a boatload of a histamine response. You get a boatload of the plasma leaking out in between the cells. You get a boatload of increased vascular permeability, and that's how all your plasma leaks out. It goes to your interstitial space, and that's how anaphylactic shock develops. So we'll talk more about it. So the scene size up here, just keep yourself safe. Number of patients, right? Make sure you remove the patient from the allergen. Looking for clues. So the book answer here is you need 2 body systems to be considered anaphylaxis. So you have GI issues and edema, or you have wheezing and a rash or hives. But that's the normal thing. So you're looking for clues for anaphylactic reaction: tongue, hives, stridor, wheezing, etc. We already had our scenario for the adult patient in anaphylactic reaction. The onset of anaphylaxis usually begins, look at this, 30 to 60 seconds. 30 to 60 seconds, which is crazy. That's quick. More rapid the onset, the more severe the reaction. Yeah, usually if somebody comes to you and says, hey, I've been feeling this for 3 days, and they may have a rash, but it's probably more of a inflammatory response, not an exaggerated inflammatory response. Want to make sure that your airway is secured, right? So if you're looking, if you have stridor or swelling in the airway, we need to really, that lets you know that you really need to get on with giving that epi as quick as you can. You want to observe for hypoperfusion, urticaria, right? That urticaria is that rash that develops. Right, so this just shows you life-threatening responses in anaphylactic reaction. You have bronchoconstriction, that increase in capillary permeability. Forgot to mention vasodilation in the little chart, but that's where that comes from. Look at here. All right, so these are smooth muscles over here, right? These are smooth muscles, right? And what happens is these chemical mediators affect that. They cause that smooth muscle to become even larger than what it is right now. And they cause it to vasodilate, becomes much larger, right? Even in a normal response, why we need that? You need that to become increased permeability, increased vascular permeability. We need to get those white blood cells down there. So we actually do, in a normal response, need those smooth muscles to vasodilate. What we don't in an exaggerated response is we don't need that to happen. All right. Your secondary assessment kind of goes, really should, I mean, you should know pretty much in your primary assessment what you're dealing with here. Your secondary assessment, you kind of do that really quick on an anaphylactic patient. Here you have hives. We have hives on the lower extremity there. All right, so clinical reasoning process is the patient has a history of or suspicious for an allergy, right? So yes and no, right? We know a lot of people are going to be first-time anaphylactic reactions with you, right? But if they've had an allergy before, this time it could be worse than the last. The big thing with anaphylactic reactions is the hypoperfusion that comes with it. Patients usually are not going to be on the fence. They're going to be seriously hypotensive, and you can put the monitor on them, right? The blood pressure, the NIBP, and you can hit it, and it doesn't give you a blood pressure. It just shows 0, 0, 0, right? You should be feeling for a radial pulse at that point. If you have an absent radial and your NIBP can't pick up anything, chances are good your patient's blood pressure is too low for the machine to pick it up. Here again, does the patient exhibit 2 or of the following 3 signs: involvement in the skin, systemic edema, or even the GI symptoms, right? So that's kind of what you're looking for. I don't get caught up in the 2 or 3. If you see that patient has, rash or hives all over them, and you suspect that it's related to anaphylaxis, go ahead and start getting ready to give that epi. So let's look at the treatment for anaphylaxis, albuterol. We mentioned that during our scenario. 5 milligrams of albuterol, probably going to be what you're going to want to go with, because the more beta, the better. And it's going to allow those smooth muscles to relax in the lungs. I mentioned leukotrienes. Leukotrienes is what actually is the cause of the constriction in the smooth muscles in the lungs. It's usually the leukotrienes that are responsible for that, right? You can assist ventilations, but start thinking about CPAP early for these patients if they're breathing like your scenario had you 28 times per minute and labored. The administration of epi, right? It's short onset. It's usually 10 to 20 minutes. I would say probably quicker than that. And if you don't have any relief in the next 5 or 10 minutes, you should be thinking about giving that second epi, or even possibly a third. And then you want your IV fluids. Remember, normal saline, 20 milliliters per kilogram. Remember what I said, take a patient's weight, 180 pounds, add a 0. That gives you 1,800 mLs to be administered. Almost 2 bags of fluid. You're going to reassess, right? You need to continuously reassess, because remember, we're dancing a fine line here. Patient's hypotensive. If you have them on CPAP, we already know that could kind of be a problem sometimes. So, but we're addressing the blood pressure with epi. But if it's been 5 minutes and you're due for a second epi, you're still hypotensive, and your patient's on CPAP, you need to be administering that epi. Same thing. Get on the phone after that. It's going to take 5 minutes to get MedControl online. Call them, get them on the line, and see where you're at. You're possibly going to need a third epi. We have to be careful in how we treat this, and we have to treat it aggressively. Right here where it says watch cardiovascular status with epinephrine use. There is absolutely no contraindications to epi when you're thinking about anaphylaxis. Hypersensitivity reactions, allergic and anaphylactic reactions. Body is exposed to that allergen. There's sensitization that happens. That's usually when they've been exposed to the allergen one time, they're sensitized to it, and then the second time's a big bad anaphylactic reaction. Not always the case, but that's the way they paint it for us to understand it. Common causes of immediate hypersensitivity: drugs, food, insects. Here's a list of those allergens: insect venom, and it goes on. Pollen, tree, weed, and grasses. The antigen enters the body in various ways. It can be eaten, an inhalation, injection, skin contact. Remember, the anaphylactoid response is kind of what I was talking about earlier. It's all anaphylactic. Don't worry about it. Angioedema is a big problem here. Here we have a picture, the most popular lady in all EMS slides. So signs and symptoms again of anaphylaxis: peripheral vasodilation. Showed you how that happens. increased vascular permeability. I showed you, tried to explain it the best I could of why that happens. Constriction of bronchial gastrointestinal muscles, right? So remember the GI problems that you can have, you don't always see with anaphylaxis, but it very well can happen. Distributive or hypovolemic shock. And don't forget about your upper airway. Here's your EpiPen. Remember 0.3 milligrams IM. Hold that EpiPen in place for 5 to 10 seconds. Treat the patient, not the pulse ox. Bag or CPAP if necessary. Epi again. IV, consider that going to do the fluid bolus of 20 milliliters per kilogram, and nebulized albuterol. Yeah, most patients do respond to the first dose of epi, but your really bad ones won't, so be prepared to give a second. Here we're going to talk a little bit about immunocompromised patients. These patients could be ones that are taking medicines for a recent transplant, cancers, they're on chemo. Here's some of these autoimmune disease processes, rheumatoid arthritis. You can read through there, make yourself familiar with those. And that's it, chapter summary. And, I'm going to summarize it by knowing anaphylaxis, knowing the inflammatory response, how we get to where we get with anaphylaxis, how we treat anaphylaxis, is all what we talked about today. All right, that is it. I will post this video, and good luck studying.